It's 8 o'clock. I want to welcome everybody who's online. I'll give it one more minute just so that the attendees and the icons log in. Hi, Rachel. Good to see you. Hi, Thiru. Janice, thanks for joining. Thank you, Elle, for joining. Good morning, Christina. Okay. So good morning, everyone, and welcome to the first Journal Club of 2024. We recognize that many Indigenous nations have long-standing relationships with the land upon which the work of the University of Toronto's Department of Medicine is conducted. Again, in an attempt to avoid the land acknowledgement becoming a performative act, today we reflect on this painting, The Red Dress, which is a reproduction of Plains Cree artist Ruth Cuthan's acrylic on canvas, How Much Was Forgotten. The use of red dresses to represent missing and murdered Indigenous women and girls was originated by Métis artist Jamie Black in 2010. In her exhibit, The Red Dress Project, Black displayed over 100 red dresses around the University of Winnipeg campus to raise awareness about this issue. Today, red dresses continue to be used across Canada as a representation of the Indigenous women and girls lost to violent crime and as a call for action to prevent future violence. We have two PGY5 presenters today. The short and first presentation by Dr. Corrie Vincent, who has a special interest in quality improvement and equity, diversity, and inclusion. She will start with a presentation on antidepressant augmentation versus switch in treatment-resistant depression. Welcome, Corrie, and please feel free to proceed. We can see your slides well. We can't hear you yet. I think you're still on mute.
Can you hear me?
Yes, now we can hear you.
Okay, sorry. I don't know, technical difficulties. Didn't want me to talk. You can see my slides, okay?
Yep, perfect.
Okay, perfect. The presentation I will be doing augmentation versus switch in treatment-resistant antidepressant and treatment-resistant geriatric depression. So I have no conflicts of interest to disclose. We're just very briefly going to go over a little bit of background information, but it's a short presentation, so we'll dive right in. So depression in older adults is common, but the estimates in the literature do vary widely, ranging anywhere between 1% and 50%. But a recent study in Ontario showed that about 20% of community-dwelling older adults who receive home care have depressive symptoms, and that this is higher in individuals that are in institutionalized settings. Treatment-resistant depression typically refers to people who have failed at least 2 adequate trials of antidepressant medication, and it's associated with decreased quality of life, functional decline, and increased mortality. I just wanted to briefly highlight that our CCSMH guidelines from 2021, this is not about treatment-resistant depression, but it's about this specific guideline comment is about people who have had a partial response. And I just wanted to highlight that often in these guidelines, we're given multiple options. So for this one, continuing the same therapy, augmenting with antidepressant, lithium, antipsychotics such as aripiprazole, doing adjunct psychotherapy, or switching to another antidepressant. But there's not a lot of literature to guide sort of which order to do these things in, which was sort of what led to the purpose of this study, which was published in the New England Journal of Medicine about a year ago. So this was a pragmatic study with a patient outcome focus. They looked at older adults who were defined as being above the age of 60, who had treatment-resistant depression, having failed at least 2 previous trials of antidepressant therapy for at least a duration of about 10 to 12 weeks. And they had to have at least a moderate severity of depression, although in the early recruitment phase, that was not a strict cutoff. It was a multi-center trial with 4 in the US and 1 in Canada. So they had 2 steps to this study in an attempt to sort of mimic clinical practice, where we pick therapies that have more favorable side effect profiles and less monitoring early on, and therapies which may have less favorable side effects profiles and more requirements for monitoring later. So in their step 1, they had patients randomized to augmentation with aripiprazole, augmentation with bupropion, or switch to bupropion. And step 2 was augmentation with lithium switched to nortriptyline. Their primary outcome was based on a patient focus group, and they suggested that the primary outcome should be psychological well-being. And the way that they measured this was using the NIH Toolbox Emotional Battery using 2 subscales. This diagram just demonstrates the flow of the study. Notably, patients and investigators were not blinded to their group assignment. As you can see, that patients were randomized by stratified block randomization to one of the 3 groups on study entry. Ignore the N values because those were different at the end of the study. This is from their design. If they did not achieve remission by the end of the 10 weeks of step 1, then they went on to be again randomized into step 2 with a further 10 weeks of therapy on the step 2 medication. Whether or not they achieved remission after step 2, they were followed for a year, and those who achieved remission after step 1 were also followed forward in time for a year. So this is just a bit more detail about all of the outcomes that they looked at. So for psychological well-being, we mentioned there was 2 surveys. They used a combined T-score average for these 2 surveys. And based on communications with the people who know this toolbox, they felt that the minimally significant difference was between 2 and 3 points. The secondary outcomes they looked at were remission from depression using the MADRS score, and they defined this as a score of less than 10. This score was done by a blinded research staff. However, if the research staff couldn't get a hold of the patient, then they used the PHQ-9 that was done at the week 10 visit. They also looked at changes in social participation and physical function. And for balancing measures, they looked at falls, fall-related injuries, and serious adverse events. For the primary outcome for psychological well-being after step 1, they used a repeated measures ANOVA with a Benjamini-Hochberg step-down procedure to control for multiple comparisons, and they used intention to treat analysis. For their secondary outcomes, because the sample size was smaller than initially anticipated, and because they were doing multiple comparisons that they couldn't adjust for, they did not comment on the significance of any of the secondary outcomes. For the safety outcomes, they used, for falls, they used repeated measures generalized linear model with a Poisson link function. And for serious adverse events, they looked at a Cox time to event model with the Anderson and Gill extension for repeated events. So this slide just has the baseline characteristics. So looking at the groups in step 1 and step 2, there's not major differences between the groups. However, the one notable difference would be for the switch to bupropion group. They do have a lower proportion of female participants. Overall, the average age was about 69, and the average PHQ-9 score was around 15, suggesting moderately severe depression at baseline or before starting the step. So for the sake of time, I'm only going to focus on the step 1 results, which was the primary outcome. So for psychological well-being after step 1, using the pre-specified cutoff p-values, we see that there was a statistically significant difference between the aripiprazole augmentation and switch to bupropion groups. The remaining comparisons didn't reach the pre-specified level for significance. So moving on to our critical appraisal. So are the results valid? So were the patients randomized? Yes. They were, and they used the stratified block randomization. Were patients in the group similar at the start of the trial? So yes, there were some minor differences, but I think overall they were similar enough. Aside from the allocated treatment, were groups treated equally? So I said no for this. And it's not so much that they weren't treated equally as they had other significant differences. So the adherence for the bupropion alone group was only 40%, whereas for both augmentation groups, it was higher, about 70%. Were all patients who entered the trial accounted for? So yes, they had a very low withdrawal rate, and they were analyzed in the groups to which they were randomized using the intention to treat analysis. Were the measures objective and were people blinded? So no, we already talked about that. Patients and investigators were not blinded. This was done to be more in keeping with sort of real world circumstances, but the outcome assessors and the rater for the MADRS were blinded to treatment allocation. So what were the results? We sort of already touched on this. In terms of the effect size, so for psychological well-being, the difference between the aripiprazole augmentation group and the switch to bupropion group had a Cohen's d of 0.37, which indicates a small to moderate effect size. I think it's also worth noting that the secondary outcomes, although they weren't tested for significance, they did provide risk ratios, and the risk ratios of the remission rates did align with the effects found from psychological well-being. So for aripiprazole augmentation compared with switch to bupropion, it had a risk ratio of 1.5, which would work out to an upper needed to treat of 10. How precise is the measure? So difference in change from baseline, they had pre-specified that they needed a minimum difference of 2 points, which they did see. But when we look at the confidence intervals, they are quite wide, which suggests that it's an imprecise measure and maybe underpowered. In terms of adverse events, there was a significant difference between the aripiprazole augmentation and the bupropion augmentation groups, in terms of the bupropion augmentation groups having a higher risk of falls. But there were no other significant differences in falls or other adverse events between the groups in step 1 or step 2. So thinking about our patients, so are our patients different than these patients? So I think some of our patients will be the same, yes, but some of them will be very different. So the average age was younger. A lot of us see people more in keeping with above 80, so that's a bit of a different population. They excluded patients who had comorbid depression or uncontrolled medical illnesses, which sometimes happens in geriatric clinics. So for those patients, these results may or may not apply. In terms of feasibility, I think mostly this is feasible. It was pragmatic. It's very much attempted to mimic the real world. However, they did call patients every 2 weeks for medication up-titration and monitoring, which may not be feasible in our general outpatient setting. And would the potential benefits of treatment outweigh the potential harms? So this study didn't answer this question for an individual medication. It provides comparisons between medications, but in terms of deciding for a patient whether aripiprazole has greater risk or benefit, you would need to go back to studies that actually just looked at aripiprazole compared to placebo. So in terms of the bottom line, so there are some potentially significant limitations to this study, specifically the lack of blinding. So patients may have perceived that 2 pills were better than 1 pill, for example, and therefore the augmentation groups may have done better. There was the lower adherence in the switch to bupropion group, which may offer an alternative explanation for why they had worse performance or like not as good benefit. Although in the nature of the pragmatic trial, if patients who are assigned to switching to bupropion tend to have less adherence, then maybe that's also a significant outcome. Lower enrollment than anticipated probably reduced their power to detect significant differences, both in their primary outcomes, but also in the balancing measures such as falls and the adverse events. So overall, this pragmatic trial provides some useful guidance in the relative efficacy and safety profiles of commonly used strategies for managing treatment-resistant depression in older adults. That's it. Thank you for your time. And did you have any questions?
Thank you very much, Corrie. I'll just kindly ask you to stop sharing so we can. So the first question, Michael, thank you for your hand. Go ahead.
Yeah, that was a very, very interesting presentation. The one issue I have is the age issue. I haven't seen anybody that young in decades. That would be like adolescent medicine for me. So, for us who are actually doing geriatric practice, although it's very interesting, I think it would be worth, if somebody wants to do it, to do a study or a comparable study in the geriatric population, the geriatricians see. This is very worthwhile for others, but I'm not sure how significant it is. And the other thing is that what's the mechanism? I mean, we know the serotonin mechanism in antidepressants, but what is it with neuroleptics? I really don't know why you get an antidepressant effect with it. If somebody knows that, I'd appreciate it.
Yeah, so I'll comment on the first part. I don't really know the mechanism, so I'll leave that to anybody else who may know. But I totally agree with the population. I think when they had originally designed the trial, so they had significant recruitment problems. They were originally planning to have about 500 people in each arm of the step one, but they ended up with only about 200. And so when they had originally done it, they had actually stratified people by age, and they were planning to do a sort of younger age being like less than 70, between 60 and 70, and then an older age group. And I think that would have been really interesting, but they just didn't have the power for that.
Thank you. Go ahead, Christina.
Hi, Corrie. Great presentation. I actually have a question that's related to what you just said, so it's a good segue. My wonder is, because I didn't read this in the paper either, is about the fact that they had to significantly shift the sample size. And did they comment about still having the power to detect a clinically relevant change? Because that obviously would be important. You'd think going from 1,500 to 600 is a huge difference, and it might really change their power to detect a clinically significant difference.
Yes, so I didn't have time, obviously, to get into everything during the presentation, but they did do an adjusted power calculation, knowing that their sample size was going to be different. And they found that they had 80% power to detect a difference of 2.6, which they felt was still clinically, like that was sort of minimally clinically significant between this people in the step one. So step two, they sort of said, we really don't have enough power. We can only comment on maybe if they had worse falls or anything like that. But for step one and for the psychological well-being measure specifically.
Okay, so it was just barely clinically significant then. It was, but yeah, very close. Okay, and then I just on that also note, and this might be something that maybe Dr. Cohen or one of the geriatric psychiatrists can answer, but I always wonder in these augmentation versus switching trials whether, you know, you lose the effect of like the first drug when you switch. Even if that effect wasn't as good, it still might have been doing something, and you wonder whether that might have actually been driving the impact and the difference that we're seeing, you know?
For sure. And I think it's also worth noting that the time for both was 10 weeks. And so when you're switching a medication, you're like, you have more of like you have to stop the other one and then you have to sort of ramp up. They did sort of stop it, I think before the 10 weeks started, but it's still, you're sort of starting from nothing as opposed to starting from something and adding. So yeah, I don't know if anybody else has.
Great, thank you. There's a comment from Ariel in the chat box. Curious if you know why they use the well-being scale as the primary outcome rather than a purely depression scale. So is this toolbox NIH validated, and why that was used?
So it was entirely because they were trying to do a patient-driven outcome. So they had, and it was sort of, I think, also based on where their funding was coming from. Their funding was coming from patient-centered outcome group. I can't remember the name, sorry. But because of this, they had stakeholders who were patients, and they presented them with options, and then the patients chose that psychological well-being was the highest priority. The plan had been to also look at remission, which would have been their more like clinically relevant one, using the MADRS scale, but and actually that was supposed to be a primary outcome, but because when they did their repeat power calculation, they had to sort of let some things go.
Great, thanks. Ariel replies, fascinating, love it. And I will also comment, do you know if aripiprazole has been genericized and covered, or is aripiprazole still?
I'm seeing some people nodding that it is not, but I actually have no idea, sorry.
And then you wonder about the funding source of the study. And lastly, the other thing I was surprised, we reviewed this paper before the last CGS, and the rate of falls seemed very, very high for a younger, older adult population, and that might reflect or higher than the community incidence we typically quote. And so more than 40% were suffering more than one fall in the last 6 months. So I wasn't sure if that reflected the impact of depression on younger, older adults and their balance, but a little bit of a concern with an anti-dopaminergic agent moving forward in that balanced population.
100%. Yeah, they definitely had higher rates of falls. I think my takeaway was that these patients were not patients with mild depression. These were like moderately severe. So these were people who are really suffering from their depression. So probably patients who are going to be trying to optimize and like give them a better quality of life anyways. And so from that perspective anyways, I thought that it was reasonable that they were trying these medications, but yeah, definitely they have higher risk of all of that versus.
Great, thank you. So Barb does put that generic is available of aripiprazole, and Karen De Silva in the chat box mentions antipsychotic benefit may have to do with dopamine receptor inhibition. So increased dopamine available in the chat box. So thank you. It comes to 20 minutes. And the study, Christina clarifies too, the study was not funded by the industry. So thank you for those clarifications. Thank you, as usual, Corrie, for an excellent presentation and very rich discussion. We appreciate it. And we will move to our next long presentation by Dr. Gabriella Jacob, also PGY5. And Dr. Jacob has a special interest in older adult perioperative quality improvement, and here to present on our new osteoporosis clinical practice management guidelines. Gabby, please go ahead.
Thank you for the introduction. So yeah, I'll just get right in. I'm going to do something a little bit different for Journal Club. As opposed to presenting an article, I'm going to present an entire guideline. And this is from October 2023, which was published in the CMAJ. So I don't have any conflicts of interest. The objectives today, I'm going to review the updates from the 2023 osteoporosis guideline. I'm going to explore the evidence base for the guideline recommendations and highlight some of the current knowledge gaps and future directions. I was lucky enough to be on an osteoporosis elective just recently, and so I was able to speak to a number of the authors, and I did get some insights and practical tips from them, which I will share along the way. So I just want to start with a case. So this is a 70-year-old female presenting to your office with a history of falls. They have a past medical history of hypertension, dyslipidemia, osteoarthritis, osteopenia. They have their medications as listed, and their BMDs show a T-score of -2 at the hip and -2.5 at the lumbar spine. So I want you to think about how you would treat this patient. So I'm going to start off with the diagnosis of osteoporosis. So osteoporosis is a skeletal disorder reflecting poor bone strength, leading to increased risk of fracture. The standard criteria for diagnosis is based on a bone mineral density of 2.5 or more standard deviations below peak bone mass. And as T-scores decrease, there's a relative increased risk of fracture. Since the last guideline, there's been recognition that osteoporosis can also be diagnosed clinically on the basis of fragility fractures or high-risk scores. So that's reflected here. So clinical diagnosis of osteoporosis based on an age of over 50 and also having had a low trauma fracture or an absolute fracture risk of more than 20% in the next 10 years. In terms of the 2023 guideline, it's separated into 6 different sections, each focusing on a different aspect of osteoporosis management. I've highlighted new practice updates from the 2010 guideline with a red asterisk and included the levels of evidence for the relevant recommendations. Of note, a strong recommendation is one where the desirable consequences clearly outweigh the undesirable consequences, and something that most individuals would want. A conditional recommendation is one where the desirable consequences probably outweigh the undesirable consequences, and most individuals would want the suggested course, but many individuals may not. So starting off with exercise, this is now recommended for all individuals over age 50, as opposed to solely those with osteoporosis, reflecting a primary prevention approach. As compared to the prior guidelines, this guideline places a focus on balance and functional training for all individuals, whereas previously this was only recommended for those considered at risk of falls. And this is a strong recommendation with moderate certainty evidence. There is still a recommendation for resistance training, but this they recognize as a conditional recommendation with lower certainty evidence. So let's take a look at the literature. So the balance and functional training recommendation comes from the systematic review in 2019 that was at Cochrane, and it actually found that based on 39 randomized control trials, there was a reduction in the number of falls by 24%, which was high quality evidence, and a reduction in fall-related fractures by 56%. Although this was based on a much smaller number of trials, there were 7 randomized control trials for the fracture outcome, and this was lower quality evidence. They could not find a certain effect for resistance training without the balance and functional training, dance, or walking on the rate of falls. Resistance training was examined in a systematic review in 2021 compared to usual care, and this included 51 randomized controlled trials. And they could not find a certain effect on falls. When looking at the numbers, there was a slightly higher incidence rate of falls in the resistance training group, but the confidence intervals crossed 1, indicating there was not a statistically significant difference. There were not enough studies with sufficient number of fracture events to pool the data for fractures, but instead they looked at bone mineral density as a surrogate for hip and fragility fracture risk. And this was based on 5 studies with 521 participants. They found an increase in bone mineral density at the femoral neck with a mean change of 0.02 gram per centimeter squared, but no difference at the lumbar spine. In terms of what this means and whether this is actually clinically significant, I did reference a JAMA observational study, which was based on the Women's Health Initiative, and they found that a change or decrease in the femoral neck of 0.01 led to an increased risk of hip fracture of 1.3. So in that case, this could be a clinically significant difference, but the evidence was rated as very low. They also looked at physical functioning based on different tests, including the timed up and go. And they found that with resistance training, there was a decrease in the timed up and go test by an average of 0.9 seconds. In terms of whether this is clinically significant, prior trials have actually indicated that a minimal detectable change in this test is more on the scale of around 1.1 seconds. So really unclear whether that is necessarily an improvement. Moving on to the nutrition recommendations. So again, the nutrition recommendations are recommended for all individuals over age 50, as opposed to solely those with osteoporosis. Compared to 2010, there is now a recommendation to encourage dietary calcium and not supplement if individuals are able to get their adequate calcium in the diet. Supplemental calcium and vitamin D recommendations follow Health Canada's recommendation, and this is a conditional recommendation. And they do suggest as a good practice statement to individualize intake of calcium and vitamin D. So for those initiating pharmacotherapy, they recognize that most trials with osteoporosis treatment had patients on vitamin D supplementation and up to 1,000 milligrams of calcium supplementation a day. And in practice, usually vitamin D levels are obtained and usually targeting at a level of at least 50 in the guidelines, but in practice, many target a level of over 75. So the guidelines cited some more recent studies in community dwelling adults as the rationale for not recommending routine supplementation of calcium and vitamin D. There was a JAMA meta-analysis published in 2017 of 33 randomized control trials looking at calcium and vitamin D, and they did not find a difference in hip fracture in these groups. There was subsequently a Lancet systematic review of vitamin D, and also did not find a difference in total fracture, hip fracture, or falls in community dwelling adults. So the guideline determined that in those with a balanced diet and not on treatment for osteoporosis, supplementation is likely to have little to no beneficial or detrimental effect on fractures. In terms of the Health Canada recommendations to ensure adequate calcium and vitamin D for bone health, That means supplementing with 1,000 milligrams for males up to age 70 and 1,200 milligrams per day of postmenopausal females. And sorry, when I say supplement, I mean getting this amount in the diet is preferred. In terms of supplementing vitamin D, they recommend that adults should get 600 international units per day if they're up to 70 and 800 international units per day if they're over 70. And that would be through dietary sources plus supplements. And because it is very difficult to get vitamin D in the diet, they're recommending a minimum supplement of 400 international units. And they do acknowledge that there are populations who are at risk for vitamin D deficiency. That would include people with limited sun exposure, people on medications like steroids or anticonvulsants, people with chronic kidney disease. And in those cases, they recommend additional vitamin D supplementation. So we're going to move on to the fracture risk assessment. This is, as per the prior guideline, recommended for all individuals who are over age 50. And they recommend looking at risk factors and assessing for signs of possible vertebral fracture in order to assess a patient's risk of fracture. I won't read out all the risk factors here, but you can see these are the typical risk factors for a fracture. With that information, they recommend determining whether to screen with a bone mineral density test. And what is updated in the guideline is that in the absence of risk factors, the guideline suggests holding off on screening until age 70, as opposed to 65, which is a conditional recommendation. They then recommend using the bone mineral density to calculate a 10-year fracture risk using FRAX preferred over the CAROC tool. There is also recommendations for obtaining spine x-rays in individuals who have an intermediate risk of fracture, meaning 15 to 19.9% with the FRAX score, or if they have a T-score of less than or equal to negative 2.5 at any site, and if they're over age 65. They'd also previously recommended this when there were clinical signs of vertebral fracture, such as height loss, wall to occiput distance, rib to pelvic distance, that were abnormal. So let's look at the studies around screening. So the evidence for screening is mostly taken from 3 large randomized controlled trials in postmenopausal females. This included the ROSE trial, SCOOP, and SOS. And in this meta-analysis, they found that screening to identify high-risk patients who would benefit from treatment resulted in reduced major osteoporotic fractures, as well as reduced hip fractures. Fortunately, there are no RCTs of screening in males that I could find, so the data is extrapolated. In terms of when to screen and the reason that they chose age 70 as the cutoff in the new guideline, they referenced this study here, which was from out of Winnipeg and out of Manitoba. And it was an observational study of 50,000 women and 4,000 men. They wanted to determine who should undergo screening with a bone mineral density to ensure that those at high fracture risk, based on a 10-year fracture risk score of over 20%, would be identified and then could be treated. They found that if someone had a FRAX clinical score, so basically the FRAX score without their bone mineral density of over 10%, and had a high sensitivity for identifying those who would then qualify for treatment when they got their bone mineral density test done. They then looked at an age cutoff instead and found that age 70 and up or age 65 with a risk factor also had similarly high sensitivity. Of note, this study excluded patients with fracture history or high-risk medication use. So the guideline indicated that a delay in bone mineral density testing in most people until the age of 70 would limit overtreatment in those at lower risk, while still identifying those at higher fracture risk. I will say that this is a conditional recommendation, and because it was based on this one observational study, which was a little bit controversial according to some of the authors, and there was some debate amongst the authors of the guideline around this recommendation. One caveat I will bring up is that the study only considered treating those at high fracture risk, whereas the guideline is now also considering treating other individuals, such as those with a risk over 15% or on the basis of low T-scores. So this strategy may not identify all of those individuals. So the FRAX score, which I've been referencing, is the WHO fracture risk assessment tool, and it uses sex, age, BMI, prior fracture, and the listed risk factors here with the T-scores or your bone mineral density results to then give you a 10-year probability of fracture, which is a numeric score that you get, and it will give you a risk for major osteoporotic and hip fracture. In comparison, CAROC uses age and femoral neck T-score in women and men, and then stratifies patients based on that into a low, moderate, or high risk category. If patients have a fragility fracture or a history of steroid use, they are automatically bumped up a category. This is a quicker method, and as a result, was previously used quite frequently. The guideline references studies demonstrating that CAROC overestimates fracture risk compared to FRAX when CAROC risk factors are present. And this study also did find a high concordance between FRAX and CAROC when there weren't risk factors present. There was another meta-analysis of different risk scores for fracture, which compared the performance of FRAX to other risk scores. This study did not include CAROC, but it did demonstrate that FRAX performed quite well compared to other tools and was one of the top 3 tools for identifying fracture risk. One of the limitations they did note was that it didn't perform as well in cohorts with men. What I will say is that one of the caveats with both FRAX and CAROC is that they both use femoral neck T-score. So if someone has worse bone mineral density at the lumbar spine, for example, this can underestimate their risk of fracture. So I'm going to move on to treatment initiation, and this is taken directly from the guideline, where it shows that as per prior, they're recommending treatment for those with previous hip or spine fractures or more than 2 fragility fractures. So hands, feet, or face don't count. The 10-year fracture risk of over 20% is another reason to treat as per prior, and those are that gives the largest benefit in those individuals at the highest risk of fracture. What is new is they've added a T-score cutoff as a reason to treat as well. So in someone who is over age 70 with a T-score of less than or equal to -2.5 at any site, they are recommending pharmacotherapy as a strong recommendation. Now, in terms of this intermediate group here, I will also draw your attention to the cutoffs. So this is a new cutoff where they are saying the 10-year fracture risk of 15 to 19.9%, or having a low T-score being under 70 is also a reason to suggest pharmacotherapy, as these individuals still benefit from treatment, although the benefit is of intermediate as opposed to of the largest benefit. So in terms of who to treat and what they put in the guidelines do acknowledge that there is a lack of consensus on who to treat. Previously, treatment was recommended in patients with fracture history with a risk of over 20% over the next 10 years. And that cutoff was based on consensus, informed by the prior cardiovascular risk thresholds, and supported by cost-effectiveness trials in the United States. But since 2010, there has been new developments in the field of osteoporosis, and the decision to treat really needs to consider fracture burden in the population, as well as economic considerations. And of note, since 2010, there has been a dramatic reduction in the cost of generic bisphosphonates as well, favoring treatment in most individuals. In terms of the rationale for treating those with T-scores of less than or equal to -2.5 or history of fracture is based on the treatment trials, which have generally enrolled these individuals and found a reduction in fractures. So the meta-analyses and studies have demonstrated about a 20 to 50% risk reduction for fracture in individuals with T-scores of less than or equal to -2.5. The guideline also cites an observational study that looked at the best strategy to identify those at high fracture risk who would benefit from treatment and prevent the most number of fractures. And in this study, they actually found that for younger individuals, the total hip T-score was more helpful for predicting the risk of fracture. Whereas in the older group, having the FRAX score of greater than or equal to 20% was more predictive of their fracture risk. So certainly this recognized that maybe FRAX underestimates risk in age less than 65, and certainly T-scores should also be used as a consideration for treatment. So moving on to the decision of which treatments. So what is new in the guideline is that for people initiating treatment, the first line therapy is a bisphosphonate. And denosumab is now recommended in those who have contraindications or substantial intolerance or barriers to a bisphosphonate. And there needs to be a commitment to long-term therapy. And we'll go over a little bit about why that has been made as a recommendation. There's still recognition of the importance of anabolic therapy in those with severe vertebral fractures or more than 2 vertebral fractures and low T-scores. So in terms of the evidence for bisphosphonates, there's a meta-analysis of postmenopausal women published in 2019. This looked at 107 randomized control trials of close to 200,000 women. And in these trials, which followed individuals for a range of 3 to 120 months and included women with primary osteoporosis or osteopenia, they found a reduction in hip fracture with relative risk of 0.61 at the hip, 0.84 for non-vertebral fractures, and 0.57 for vertebral fractures. And this was for alendronate, but there was similar relative risk reductions for the other bisphosphonates. In men, there is a smaller meta-analysis. This had 22 randomized control trials, with each trial having between 23 and 1,000 patients, with trials ranging from 1 to 3 years. And they found that there was, again, a reduction in non-vertebral fractures with good reduction, relative risk of 0.6, and decrease in vertebral fractures, although this was not significant for clinical vertebral fractures, only for radiographic vertebral fractures. In terms of the reason that denosumab has now been suggested as a second-line therapy, is that there have been increasing recognition of the risks of stopping denosumab. This was a systematic review that was published in 2021, referencing studies that have found an increased risk of clinical vertebral fractures and multiple vertebral fractures when stopping denosumab. And in the RCT Freedom Extension trial, this was also seen, where there was an increase in multiple vertebral fractures in the group that stopped denosumab compared to placebo. In the analysis of Freedom Extension trial, they found that the bone mineral density loss off treatment was greatest in individuals who then sustained multiple vertebral fractures, suggesting that it's the rapid bone loss that puts people at risk. So as a result, there have been strategies developed for denosumab discontinuation with switching to a bisphosphonate. And these, some of these recommendations are included in the guideline, but I did not have time to review this today, so something that you can reference. In terms of anabolic therapy, they've also included some trials for your reference, but those are in my supplementary slides. So moving on to duration of therapy and sequence. So the guidelines are now being much more clear about how long to treat for. So they recommend treating initially for 3 to 6 years and favoring the 6-year mark for those who've had a history of a hip vertebral fracture or multiple non-vertebral fractures, or those who've had new or ongoing risk factors for bone loss or a decline in bone mineral density. Certainly, they also recommend that if there's not a good response or there's a fracture on treatment, then switching or extending your therapy would be recommended, and seeking advice from an osteoporosis consultant can be helpful. After that initial treatment period of either 3 or up to 6 years, they're recommending stopping therapy for a drug holiday and reassessing in a couple of years to determine whether to resume treatment. And we'll go over the rationale for this. So the guideline cites a systematic review, which included randomized control trials and observational studies looking at long-term use compared to discontinuation. And they found that in those who continue to bisphosphonate for more than 5 years versus stopping, or zoledronic acid for more than 3 years, there was no difference in non-vertebral fractures. There were some negative trials and some positive trials in terms of a reduction in vertebral fractures, so that is still unclear. We don't have any evidence or studies in men in particular. However, there is recognition that there are harms with with longer durations of therapy. So in this study, which was published in Denmark, they looked at osteonecrosis of the jaw with patients who had been taking bisphosphonate for more than 5 years. And they found that the odds ratio for ONJ was 2.31. And in another study from Kaiser Permanente and published in the New England Journal of Medicine in 2020, they found that patients who received bisphosphonates for 8 years had a much higher incidence of atypical femur fracture when compared to if they had taken them for only 3 to 5 years. What's interesting is that these risks decrease significantly by 1 year after discontinuation. So for example, in this study, they found that for those who had just recently stopped compared to those who'd been off for 1 year, they had much higher risk of ONJ. So once you had basically been off this for a year, your risk went down a lot. And similarly for the atypical femur fracture. So in chatting with the osteoporosis experts on my elective, the understanding is that the risks decrease back down to zero by 1 year after stopping. And it's as if you're resetting the clock. And then you can consider another treatment course where you're again starting with a very low risk of AFF and ONJ, but you're still getting that fracture risk benefit when compared to uninterrupted therapy, where you start to have an increased exponentially risk of AFF and ONJ, and that could start to tip the scales in terms of the risk benefit of these medications. I'll contrast this with denosumab. So the Freedom Extension trial looked at denosumab for up to 10 years of treatment. And when patients continued this for more than 3 years, they found an ongoing reduction in terms of vertebral and non-vertebral fractures and an increase in bone mineral density. I will say that this trial used a virtual long-term placebo cohort from year 3 to 10, which used a simulation method to develop this virtual cohort. What is interesting, though, is the risks over time with denosumab long-term is felt to be relatively stable. So in this study, and this is from the Freedom Extension trial, and they reported the incidence of AFF and ONJ across the entire trial. And AFF was only identified in 1 patient at year 7 and 1 patient at year 3, whereas ONJ was reported in 7 at year 10 and 6 in year 7 of treatment. What I will note is that looking at this table that I found in the appendix of the article, there did seem to be a higher risk at year 6 for the ONJ, which was not commented on in the study or in the guideline. But currently it is felt that ongoing denosumab therapy is safe. So in terms of the monitoring recommendations, the new guidelines are recommending repeating a bone mineral density 3 years after initiating pharmacotherapy. This is updated from before, where they recommended doing a bone mineral density every 1 to 3 years. Now it seems there's more of a push to reduce unnecessary testing. If there's unlikely to be a change in the management, you're just going to continue the bisphosphonate for the time rate up to 3 years, then really suggesting it's not going to be necessarily helpful to repeat the bone mineral density before that time. They do acknowledge that you can repeat it in patients who have risk factors, new fractures would certainly be indicated. And they recommend against using a FRAX tool or another risk assessment tool to determine whether there's been a response to therapy. Rather, you should follow to see if there's any clinical fractures that develop or whether there's any changes in the bone mineral density. So in terms of why they are making these recommendations around monitoring, so there is very limited evidence around monitoring of bone mineral density tests. The guideline cites a cohort study in Manitoba, which found that in patients who had a repeat BMD within 5 years of starting treatment were more likely to stay on treatment and also were less likely to have fractures. And so in the osteoporosis clinic, it is felt that if patients are continued to be monitored, they're more likely to maintain adherence to the medication, they're more likely to actually have improved outcomes as a result. And also what I will note is that patients who are monitored were more likely to switch to an alternative therapy. So it is important that patients are monitored again, because if the therapy is not working, there are alternative options that could be tried. Another reason to have monitoring is that patients want to know that the drugs that they're taking are working, or at least that there is some continued reason that they should be taking these medications, especially for oral bisphosphonates, which can be quite cumbersome to take. So I want to go back to the case and go through some of what we would recommend for this patient. So in terms of exercise, certainly a lot of focus would be on balance and functional training to reduce the risk of falls. And resistance training would also be helpful, but again, the evidence for that is lower. We'd recommend the patient get enough calcium in the diet, 1,200 milligrams per day, and would supplement the patient with vitamin D. We'd recommend that the patient be treated on the basis of bone mineral density of negative 2.5 at the lumbar spine. So she is 70, and so she is in that high risk category based on her BMD. I did put her information also into a FRAX risk score, and actually it put her risks of major osteoporotic fracture at 9.6%, which again would not qualify her for treatment. So I think, again, important to use that T-scores as well as a rationale for treatment. And given that she has low T-scores at the lumbar spine, obtaining spine x-rays would be indicated. This patient would be suitable for a bisphosphonate, at least a trial to see if they tolerate the oral bisphosphonate, and would treat for 3 to 6 years, depending, 3 years if there's no other ongoing risk factors, no known fractures, and then would give a drug holiday with a repeat bone mineral density at the 3-year mark. So I'd want to just acknowledge some of the knowledge gaps that we went through throughout the presentation. So it is still unclear about exactly when to screen and how frequently to screen. Certainly the treatment thresholds are still up for debate, and there is limited studies in males, so we're often extrapolating the data there. There is a question about the safety of long-term use of denosumab, as we have not seen patients on this drug kind of indefinitely, and that's something to watch. And then also the question of how to safely discontinue denosumab is certainly one that is going to continue to be studied and evaluated. And with that, I would like to open it up to some questions. Thank you for your attention.
Thank you very much, Gabby, for an excellent presentation, incredibly informative and detailed on the new guidelines. Can I ask you to stop sharing these slides just to reestablish the format? And there's many comments in the chat, which I will get to in a moment, but first Shabir has his hand up. Go ahead.
Actually, maybe you would take some of those comments first, and then I'll go after. I think there's some great questions in the chat.
Sure. So Irene Turpey asks, regarding vitamin D, many of the studies do not consider skin color, and having non-white skin may be an additional risk in our Canadian winters. Was this considered?
Yeah, they don't comment on that in the guideline. And I think the guideline is very clear that they're looking to really, they're not going to recommend a specific vitamin D dose for all comers, because there's not evidence that they have to back that up. So they therefore aligned with Health Canada to say this is what is recommended for adequate bone health. And they do say that in those who you think might be at risk for vitamin D deficiency, you should consider supplementing additionally to that 400 international units.
Okay, thank you. Gagan Sarkaria writes, men were not included in some of the studies. Are there any changes in guidelines for screening and treatment in men specifically?
It's a great question. So there aren't, as I mentioned, no screening trials in men, but they just said, well, probably similar to females, we're just going to screen men just the same as we do women. So still it would be the same. Men would be screened at age 70, unless there's other risk factors like hypogonadism, which you would screen earlier because of that presence of a risk factor.
Okay, thank you, Carolyn. Thank you for your comment. And Karen De Silva says, sorry, it's just jumping around.
I think Christina had a comment on like where the
yeah, do you have a
is.
sense of how many recommendations came from systematic reviews, RCTs, compared to lower quality evidence?
Yeah, so the meta-analyses that I presented, so the risk reductions for bisphosphonates, the screening trials, those were all randomized control trials that were quite large. The RCT in men for treatment also was randomized control trials. The observational studies were the ones where they picked the age 70 cutoff for screening. That was the observational study out of Manitoba. And also the trials of maybe using T-scores as opposed to just fracture risk. That was also an observational study. But in terms of the treatment, the treatment trials and the risk reductions, those were all large-scale trials that had strong evidence for them.
Very good. Thank you. Shabir?
Yeah, thanks, Gabby. I echo the comments of others that it was a great presentation and a huge guideline to try to digest and cut into the most relevant pieces. And obviously, I think it's good for us to go back and refresh. A comment and a question. The comment is around the vitamin D, I think going back to a response to Irene Turpey. And I think most of us who worked in the osteoporosis clinic or still do will still consider getting vitamin D levels, particularly in people who are high risk and you're thinking of putting on anti-resorptive therapy, targeting, as you said, minimum 50, but most of us go to 75, and 400 units often doesn't cut it. And so although the guidelines can't give you specific dosing, we have to keep in mind that the majority of these individuals, particularly in Canadian winters and the darker skin populations, et cetera, more people who are indoors, like many of our frail older adults, are higher risk of vitamin D deficiency. And most of us will check their levels before we start anti-resorptive therapy and then aim to get them above 50 or 75. Now, we can talk about the evidence for going above 50 and the interactions with low vitamin D and bisphosphonate efficacy, but they didn't really cover that in the guideline much either. But there is some literature, much lower quality. But just keep that in mind. And the other thing to keep in mind is even our own observational data that we have from our male osteoporosis clinic at UHN many years ago when I was there, 70% of men will get vitamin D levels above 75 with 1,000 units a day. But 30% of men will need more. And this was an older population of men, mixed of white and non-white, but 75, 80% were white. So just to give a sense. So many people will need more than 1,000 units, women and men, and keep that in mind if you're going to be aggressive and put them on anti-resorptives. My question to you is around going back to the evidence, going a little bit around what Christina was asking, but in a slightly different way, that most of our presentations in Journal Club have evidence-based and we do a critical appraisal. Are you aware of critical appraisal guidelines for guidelines? And if so, did you apply that to this guideline and how did it fare?
So they use the grade recommendations in terms of how they assess kind of the levels of the evidence. So my understanding was that's how they used kind of firstly the whether it was a strong recommendation and whether it was or versus a conditional, and then based on the quality of the evidence, was it high quality or low quality? So I think that certainly, as we found, like for the areas of the guideline where there's a lot of studies with large randomized controlled trials, they, for example, the bisphosphonate treatments, like those high risk groups who to treat, those were all high, strong recommendations with high quality evidence, which I agreed, like that makes sense. And the ones that were unclear, which were based on observational studies or where there's like, some debate about whether the evidence is there, would be like the screening. And those were all conditional recommendations about the change in the age for screening. So I think that in terms of how they evaluated the level of evidence, they did well in terms of that. Yeah.
So I think that's a really important point, but keep in mind, and it's good for our trainees in the audience also, that there are other questions that are asked in the critical appraisal guidelines of guidelines. So that one of them is obviously, how did they come up with their recommendations? Did they use a formal process like grade? Did they, rate evidence and talk about what are conditional recommendations and strong recommendations? That's a really important part, but it's not the only part. In terms of how do they handle conflicts of interest? How do they do literature searches to inform the guidelines? What are their plans for considering resource environments? There's a number of other factors that should be looked at to identify the highest quality guidelines. And this is generally, from my reading of it and my critical appraisal, it's a very good quality guideline, but it's important to keep in mind that there are structured tools that we should all be thinking about in terms of questions when evaluating guidelines like this one that are going to really impact on our practice. And so thanks for sharing some of that and just keeping those other points in mind.
Great. No, that's really helpful. And I think Christina just said they had the agree to tool.
Yeah.
I don't know what that is, if Christina can elaborate or.
Sure. Christina, do you want to talk about agree to, I guess, in this case?
I don't know much about it, but I did notice that they mentioned it in their methods. And so anyways, I've looked at Agree a couple of times, but yeah, it covers many of the points that Dr. Alibi was talking about related to like, did this have like the right number of stakeholders in the, like making these decisions, for example? Did like the evidence to recommendation tables make sense in terms of going from like the quality of the evidence to the recommendation and the grade recommendation? So the grade recommendation kind of is like the end point, whereas the Agreed to tool is what they used to like
The process,
rigorously look at
consensus,
the
et cetera.
evidence. And even like external review of the guidelines, often that happens at a certain point. So I think they did go through a lot of that, but it is buried in a very large supplement.
Yeah, I'll take a look at that. That's really helpful. Thank you.
And Katrina posted the link to a summary as well. Thank you, Katrina. So that brings us to 9 o'clock. Again, a very rich discussion, and I want to thank both of our presenters this morning, Corrie and Gabby, for, as usual, exceeding all expectations with fabulous presentations. A lot of applause across the Zoom. Thank you, and I wish everyone a good Friday and weekend. We will see each other again next month.